Today's video is about germinal matrix hemorrhage or an intraventricular hemorrhage. Uh, it mainly occurs in premature infants, and risk is higher with decrease in maturity. So, if a newborn is born premature, the more premature the baby, the higher are the chances that the baby will have an intraventricular hemorrhage. And the babies who are born premature may not necessarily have the intraventricular hemorrhage on the first day of life. Is It is the most common neurologic complication in premature infants. Recently, there has been reported a decrease in the incidence of intraventricular hemorrhages, and the two important contributing factors to this decrease in incidence are: number one, the use of antenatal corticosteroids, and number two is the postnatal use of the surfactants. In premature infants who are born less than 1.5 kg, the incidence is somewhere 30%. The oral incidence of intraventricular hemorrhage in premature infants is between 10 to 25%. If we talk about the pathophysiology of the intraventricular hemorrhages, so if you look at this picture, the yellow zone is indicative of the germinal matrix. And what is the germinal matrix? So germinal matrix is actually a capillary network, and they are numerous in number, and they are thin walled, and they are large blood vessel, but there is a lack of structure support and integrity. But at the same time, they are very highly metabolically active, and it is somewhere located between the caudate nucleus and the thalamus, at the level of foramen of Monro. One another important fact about the germinal matrix that it's actually a brain structure of premature brain. So it starts involuting at 28 weeks of gestation, and at term there is no germinal matrix. So that's why we have a decreased incidence of a germinal matrix. There is a decreased incidence of intraventricular hemorrhages in term infants. So that is a structure you can see here in the yellow, and the green shows the caudate nucleus. So a structure that is prone to bleed, but at the same time there is so fluctuation of cerebral blood flow in a newborn who is born premature, because of this so many things happening with that baby. And this baby might have a RDS, might have a PDA. So the cerebral blood flow, due to many reasons, is fluctuating, and so the two things combine and lead to bleeding in premature infants. If we talk about risk factors, so there is a long list, but prematurity, genetic factors, similarly chorioamniotis and sepsis and hypoxia in newborn babies are contributing to the intraventricular hemorrhage and germinal matrix hemorrhages. If we talk about the maternal hypertensive disorders of pregnancy, such as severe eclampsia and HELLP syndrome, uh, the data is conflicting. So there is both school of thought, and there is some data that favors that HELLP syndrome and preeclampsia aid and eclampsia aid to the increasing incidence. But at the same time, we have other studies which have which shows that the preeclampsia could be protective in some cases. Similarly, mode of delivery is very important, and breech presentation is considered to be one of the risk factor for intraventricular hemorrhages. Similarly, delayed cord clamping and cord milking. So we kind of know that delayed cord clamping is and could be one of the protective factors, but at the same time, cord milking has been, you know, by many authorities believed to be one of the cause of the intraventricular hemorrhages. Similarly, acidosis, bicarbonate therapy, hypothermia, pneumothorax, and coagulation and platelet disorders and low hematocrits uh, are very important risk factors for intraventricular hemorrhages. What is the what about protective factors? So, antenatal use of corticosteroids have been documented to be one of the most important preventive factors. At the same time, the postnatal use of surfactant have also been documented to be one of the important predictive factor. And I think these two things are important in terms of preventing the RDS in premature babies, which is usually the RDS cause a lot of problems in the premature infants because they may need to be ventilated, and with ventilation there could be gas problems like there could be acidosis, there could be hypercapnia, and there could be hypoxias with the RDS. So these all things lead to a fluctuation in cerebral blood flow and eventually lead up to intraventricular hemorrhages. If we talk about the grading system, so germinal matrix hemorrhage the is classified, it's called papal grading system. So if you look at the grade 1 here, and you can clearly see that it is limited only to the germinal matrix zone, which is kind of shown in the orange in the picture, and the blue is the ventricle. In grade 2, the germinal matrix hemorrhage extends into the ventricle, but less than 50% of the volume of the ventricle is occupied or is filled with blood. In grade 3, however, this extension of hemorrhage into ventricle is extensive, and it is more than 50% of the ventricle volume is occupied by the blood in grade 3, or there is some dilatation into it of the dilatation of the ventricle. How in grade 4 is actually parenchymal hemorrhage, and it involves the extension of the bleed into the brain parenchyma. Here are three known presentations. So one is silent, the other one is saltatory, and the third one is the catastrophic. So silent presentation is usually detected by ultrasound screening, and there is no manifest signs in the baby. And saltatory or stuttering cause, which is the most common clinical presentation in these babies, the symptoms are subtle, and in the catastrophic, the baby can have coma, prostrating, respiratory symptoms, and seizure. And on examination, they can have papillary changes as well. What is the diagnostics that we use? So cranial ultrasound is the recommended, and for mode of modality, and for babies who are born less than 32 weeks of gestation or less than 1.5 kg will need ultrasound. So 50% of these babies will have intraventricular hemorrhages on the first day, while the 90% will have in the first 3 days of life. So if you see this very particular table that I have shared and added to this slide, is that for detection of periventricular hemorrhages, the ultrasound could either be done on day 1st or day 3rd or day 7th. So it depends on the clinical course of the baby as well, and the mode of delivery, and so many other factors. So, but we can kind of say that at day 3, 90% baby will have bleed. So I think the decision to go for an ultrasound will depend on so many factors, logistic being one reason, but at the same time is the clinical presentation of the baby as well. And on day 28, we do an ultrasound, which is primarily to look for a periventricular leucomalcia. We'll talk about later on in a minor detail. How do we manage intraventricular hemorrhage? So the most important thing is to maintain normal tensive environment in the baby, and that will lead to stable cerebral perfusion. And at the same time, we have to keep the glucose and electrolytes in a normal range. If there is coagulopathy or anemia, we have to correct shock and acidosis by volume and fluid resuscitation. And if we talk about the one complication of the intraventricular hemorrhage, which is post-hemorrhagic hydrocephalus, so it could be treated with ventricular peritoneal shunt. And at the same time, we have to measure head sizes, and a greater than 2 centimeter per week size is kind of indicative of the post-hemorrhagic hydrocephalus. What is the sequelae of the intraventricular hemorrhages? So the two most feared and I would say the complication of the intraventricular hemorrhages is the post-hemorrhagic hydrocephalus, which could be transient or persistent, and at the same time could be communicating or non-communicating. The pathophysiology of the obstructive hydrocephalus is usually the obstruction at the level of the aqueduct of salivis or the outlet foramen of Luschka megendi, while the communicating or the non-obstructive hemorrhagic ventricular dilatation is usually due to the obliteration of the arachnoids. And the second most common complication is the periventricular leucomalcia, and it is the white matter abnormality that follows intraventricular hemorrhages. Seizure, cerebral palsy, and mental retardation are the sequelae actually. That could be both. So seizure could be short term, or that could involve epilepsies as well. Cerebral palsy and mental retardations are the long term complication. How we prevent intraventricular hemorrhages? So antenatal steroid and prevention of premature birth are the two most important factors. Similarly, if the baby has to be delivered, labor and delivery should be optimally managed, and postnatal endomethacin has noted to be one of the uh, preventive measures that could be taken. Not all the units use endomethacin, but there is supportive evidence that it could help in preventing the intraventricular hemorrhages. Thank you.